Good evening, everyone. I'm Peter Ehrlich, and I'm a pediatric surgeon from the University of Michigan, and my partner tonight is...
Hello, I'm Jenny Aldrink. I'm one of the pediatric surgeons from Nationwide Children's Hospital in Columbus, Ohio.
We're both members of the APSA Cancer Committee, and this first case was put together by Dr. Rito Barshinger and Dr. Krista Grant, and it is entitled Management of Lung Nodules in Patients with Wilms Tumor. So a 3-year-old presents with an abdominal mass that's consistent with a Wilms tumor. On cross-sectional imaging, was also found to have multiple pulmonary lesions. Jennifer, what is the next step?
As you know, primary nephrectomy can alter treatment and impact late effects in patients with metastatic lung disease. Wilms tumor is staged as an abdominal stage as well as an overall stage. Abdominal stage can still be stage 1 or 2 despite the presence of metastatic disease. So even in the setting of stage 4 disease, favorable histology Wilms tumor, local stage is very important. Local stage will impact the need for abdominal radiation therapy, and therefore performing a primary nephrectomy whenever possible and sampling of lymph nodes at the time of nephrectomy is of extreme value, even in the setting of stage 4 disease. Although the pathology of the primary tumor and the metastatic lesion has rarely been reported to be disparate, tissue from both sites are currently not required on current study.
This patient then undergoes a primary nephrectomy and has stage 2 abdominal disease with favorable histology Wilms tumors. After 2 cycles of chemotherapy, the repeat chest CT scans shows complete resolution of the lung lesion. Jennifer, what is the next step?
This patient does not need pulmonary radiation. This patient is considered a rapid complete responder and therefore can be spared the radiation to the lungs. The management of pulmonary disease in patients with Wilms tumor has recently changed. Recent COG and SIOP studies have shown groups of patients, if given chemotherapy with complete resolution of lung nodules, can be spared radiation therapy to the lungs with similar event-free and overall survival to those who did receive chemotherapy and radiation. These are considered rapid complete responders. Importantly, in this study, 46% of patients were spared pulmonary radiation initially. This is a very important graph, as the long-term risks of radiation therapy to the lungs can include diminished pulmonary function, congestive heart failure, and secondary malignancy, particularly breast cancer. Nearly 2,500 female survivors from the National Wilms Tumor Study 1 through 4 were followed long-term for the development of breast cancer. Of those who received pulmonary radiation, nearly 15% developed invasive breast cancer by the age of 40.
What if the same patient following 2 cycles of chemotherapy with DD4A underwent a repeat chest CT scan revealing just a single left pulmonary lesion? Would that change your management?
In this patient, a thoracoscopic biopsy of the pulmonary lesion should be strongly considered before escalating therapy. Several studies have shown that not all lesions have viable tumor. SIOP demonstrated that those with necrosis and non-viable tumor did well without radiation therapy, with comparable event-free and overall survival. On AREN 0533, of those patients who had a partial response or stable disease, 8 patients with stable disease underwent biopsy, of which 7 were not tumor, and 15 patients with partial response underwent biopsy, of which 9 were not tumor. A retrospective feasibility study of 0533 patients were performed, including 80 patients with between 1 and 3 pulmonary nodules. And it was determined that of these 80 patients, 35% met criteria for thoracoscopic biopsy. Therefore, select patients may be good candidates for surgical biopsy and potentially avoid pulmonary radiation. In an upcoming COG study, there will be a recommendation that patients with minimal residual disease, such as 4 or fewer peripheral lesions, be recommended to undergo thoracoscopic resection to determine pathology. In those patients with benign disease or have complete necrosis Wilms tumor, radiation therapy can be avoided, therefore decreasing the risks of late effects. Our second case tonight is on the topic of bilateral Wilms tumor. This case was assembled by Dr. Elizabeth or Lisa Tracy and Lindsay Talbot. The case information is a 3-year-old who presents to her pediatrician with abdominal pain. On exam, she is found to have an abdominal mass, and the following imaging is obtained. This CT demonstrates an axial cross-sectional view of bilateral renal masses. So what would you do?
It's now been shown that the best next step for this patient is to give 2 cycles of 3-drug chemotherapy and reevaluate with cross-sectional imaging. This patient has bilateral Wilms tumor. They tend to present younger. 10 to 20% will have a recognized underlying genetic condition like Beckwith-Wiedemann. And the balance is between oncologic outcomes and saving kidneys. We have chosen, based on prior research from our colleagues in SIOP, that induction therapy without tissue is the best place to go. The reason is these are almost uniformly Wilms tumor. The second reason to proceed with therapy without tissue is that it is very difficult on biopsies to determine whether a patient has anaplasia or not. And the initial therapy for both these cases is the same, so it makes sense to treat them without tissue.
This patient did receive 2 cycles of 3-drug chemotherapy, and the tumors responded with approximately 30% reduction in overall volume. So an additional 2 cycles of chemotherapy were given. At week 12, no further reduction is seen in the size of the lesions. What would you do, Peter?
The bilateral partial nephrectomies can be performed in this patient. Prolonged chemotherapy has been shown not to result in any further shrinkage of the tumor. In fact, several papers have shown that prolonged chemotherapy can result in acute toxic effects, as well as selecting out clones that are more unfavorable to the patient. Patients who don't respond to chemotherapy have generally fallen into 2 categories. The first is that the tumor has undergone maturation or rhabdomyomous changes. And while those changes will make it resistant to chemotherapy, the overall oncologic outcomes are excellent. The second is that there's not responding because there's a significant amount of anaplasia within the tumor itself. And that is why for patients who do not respond by 30% by volume, it is recommended that they undergo biopsies of both kidneys before continuing chemotherapy. The technical aspects of bilateral Wilms tumor surgery are challenging. As opposed to renal cell carcinoma, Wilms tumors can be quite large, but tend to compress the native kidney, making it seem that it is taking up more space than it actually is in the kidney. Secondly, Wilms tumors after chemotherapy, a large majority of them will become encapsulated, and while they look large, they will often be easy to take out. As is shown in the 2 slides on the right of the screen, this is one of the tumors that we saw on the CAT scan, and you can see that after entering the kidney itself, the Wilms tumor itself is encapsulated and can be easily shelled out, leaving a significant amount of kidney intact. And it is very important to properly assess the kidney and its vasculature before making a definite decision to remove it. Our third case tonight is management of Wilms tumor with IV3 thrombus. It was put together by Dr. Peter Matai and Dr. Bindi Naik Mathura. Case begins with a 3-year-old who presented with abdominal distension. Cross-sectional imaging showed a renal tumor, and IV3 thrombus extending to the level of the hepatic veins. Jennifer, what is the next step?
Biopsy to confirm Wilms tumor. The presence of tumor thrombus in the IVC represents some of the most challenging cases to manage in children with Wilms tumor. Historically, these children were managed with aggressive nephrectomy, cardiopulmonary bypass. However, there were extremely high morbidity and mortality rates in these patients. In 2001, Schamberger and colleagues demonstrated that preoperative chemotherapy could reduce the incidence of major complications in these patients by 26% without sacrificing oncologic outcomes. One of the key determinants of the timing of operation initially is the extent of tumor within the IVC. In the setting of tumor thrombus with extension to the level of the hepatic veins or above, patients should be considered for tumor biopsy only, followed by neoadjuvant chemotherapy. In some instances, patients with extensive tumor thrombus extending into the right atrium or the pulmonary arterial outflow tract can present in severe respiratory distress or congestive heart failure, in which case beginning therapy without a tissue diagnosis is acceptable.
This patient was not symptomatic and underwent a biopsy, followed with 12 weeks of neoadjuvant therapy for Fabry histology Wilms tumor. The primary tumor size was smaller, and the IV3 thrombus regressed to the ureterohepatic inferior vena cava. After mobilization of the kidney and the tumor, the IVC was then evaluated for extent of thrombus with intraoperative ultrasound. Jen, what are your surgical options at this point?
There are several considerations when dealing with an IVC thrombus in the setting of Wilms tumor. When the tumor thrombus clearly extends to a point below the hepatic veins where control of the IVC is considered feasible and safe, one may reasonably proceed with upfront nephrectomy. For those that extend to the level of the hepatic veins, it should be determined preoperatively whether cardiopulmonary bypass is required for total extraction of the tumor thrombus. Tumors that remain within the right atrium or beyond can safely be removed following initiation of cardiopulmonary bypass. Tumor present in the supradiaphragmatic IVC also usually require cardiopulmonary bypass depending on the length and extent of the tumor. Performing a transesophageal echocardiogram and/or an intraoperative ultrasound is of great value in assessing the location and extent of the tumor and its adherence to the vessel wall. If it is confirmed with reasonable confidence that the thrombus is free-floating, it might be reasonable to consider controlling the suprahepatic IVC just below the diaphragm and removing the thrombus from below. Using either a balloon catheter of adequate caliber to perform the thrombectomy is an excellent technique when not attached to the IVC wall. Tumor thrombi that are found to be adherent to the IVC wall, the tumor can be carefully extracted using a technique similar to an endarterectomy. If the wall of the vessel is directly invaded, local resection or patching, or even en-bloc IVC resection may be performed for complete resection. However, in this setting, complete resection with negative margins of an intravascular Wilms tumor may not be reasonable or safe, and it does not necessarily preclude good outcomes for the patient. The goal is, of course, to remove as much as possible without undue morbidity. Leaving a small amount of residual treated tumor is sometimes unavoidable, and the exact location should be documented carefully and reviewed with the radiation oncologist for postoperative radiation planning. So our fourth case of the evening is on the topic of diffuse hyperplastic perilobar nephroblastomatosis. So Peter, this is a 13-month-old patient with no past medical history, presents with recalcitrant constipation and abdominal distension. On physical exam, this child was found to have an abdominal mass and underwent cross-sectional imaging that included this CT scan. What do you think, Peter?
This pictures represent one of the rarest lesions that we see in patients with renal masses. This is diffuse hyperplastic perilobar nephroblastomatosis, and this is a pre-malignant lesion. Diffuse hyperplastic perilobar nephroblastomatosis, or DHPLN, is defined as the cortical surface of the kidney being composed of hyperplastic rests with the entire nephrogenetic zone involved with a thick rind capping one or both kidneys. And inside these rests can be focal areas of Wilms tumor. Nephrogenic rests are clusters of embryonic metanephric cells. There are two types that are described. Both are important in the development of Wilms tumors. There are perilobar rests and intralobar rests. Rests can be hyperplastic and grow, or they can be dormant. The persistence of a rest beyond 36 weeks gestation is abnormal. And rests can give rise to Wilms tumor. Intralobar rests are recognized as precursor for Wilms tumors in patients with Wegar syndrome, and perilobar rests are precursors for Wilms tumors in Beckwith-Wiedemann syndrome. Genetically, Wegar syndrome patients have the WT1 mutation, and Beckwith-Wiedemann syndrome have the IGF2 mutation.
What's the next best step?
So the best step is to start chemotherapy with 2 drugs and re-image after 2 cycles. Patients with diffuse hypoplastic perilobar nephroblastomatosis, if left untreated, 100% will develop Wilms tumor. A biopsy in these patients cannot differentiate between a Wilms tumor and a nephrogenic rest. And unfortunately, this is one of the more common mistakes made in the management of these patients. Biopsies to determine a rest from a Wilms tumor, you must be able to look at normal kidney. A Wilms tumor will have a capsule around it, whereas a rest, there will be no capsule. A core biopsy or a needle biopsy will simply not get enough tissue, and you will not be able to tell the difference of whether it is actually a Wilms tumor or a rest.
So the images to the right now show DHPLN response after 4 cycles of chemotherapy. Based on these images, what is your management now, Peter?
Management of these exceedingly rare cases is somewhat disparate. In most cases, our colleagues from PSYOP and us would continue chemotherapy. However, the duration of the chemotherapy is somewhat different. The PSYOP group will typically treat these patients for 1 year with 2-drug chemotherapy, whereas on the recent 534 study, these patients were treated for just 19 weeks. The concerns about prolonged treatment have been that some patients with prolonged chemotherapy developed anaplastic histology thought to be by selection. The problem with the short duration of chemotherapy did not prevent the development of Wilms tumor in about 1/3 of patients. However, in both treatments, most of them are alive and most have good kidney function. There are several difficult and challenging questions that require further study. The first is imaging. Very difficult to determine whether something is a rest or a Wilms tumor. And that is even more difficult in the setting of DHPLN, where normal kidney tissue can be difficult to locate. Pathologically, initial biopsies can be of limited value, particularly if they're either core or fine needle. And ultimately, goals of therapy need to be reevaluated. Prevention of Wilms tumor may not be possible in all patients, and short course of chemotherapy did not appear to alter significantly the course in patients. However, longer courses do have negative effects. As mentioned earlier, most children who have the disease tend to be alive and have kidney function.